All right. So, week one, what is physical therapy and the history of physical therapy? So, first off, these are our learning objectives. Every single class you have should have learning objectives to it. How many people this is their first semester of college? How many of this is your first year of college? Or how many of you there's been a big gap in between the last time you had college? So, um, every single thing you ever learned should come back to a learning objective. And all of my written exams are going to come back to these. So, how many people know they like studying with like flashcards? There's your flashcards right there. Now, I mean, we've got 7 learning objectives. There, this first one, you're gonna have like 4 different definitions, I think. So, like, they'll turn into maybe 20 or 30 flashcards. But there you go. There's your study. You guys want to like a study guide? There's your study guide right there. Okay. So the first thing that I'm going to make sure you guys understand is the learning objectives are the things you have to learn. We'll come back to these in a little bit. All right. So we're going to watch this video. Sound works. Hopefully it does.
Dentists hate when you do this, but they can't stop you. This new $100.
I teach, I learn, I treat. You need to go in with a completely open mind because something very cool might come out.
Here at the National Rehab Hospital in Washington, D.C. This is the cardiac rehab. So we're working with patients with heart conditions. You get to use your thinking skills, analytical skills, problem solving. I mean, they're BP 135 over 95. You get to do so much. It's really awesome.
Right now we're in Independence Square. It gives the patients an opportunity to practice the things that they've been working on in a real world setting. So this is a kitchen that we're in right now, and it's set up just like any other kitchen. The sink works, it's got knives, it's got plates, it's got food, and you get to practice. The best thing about being a physical therapist is getting to see your patients improve. When you get to see them go home on that last day and they're walking out when they came in a wheelchair or they came on a stretcher, and you get to see them leave, walking over to your destination.
We'll walk down, touch the wall, come back to the exact same spot. I'm a board certified neurospecialist. I see everything from spinal cords to people who are dizzy, stroke. I mean, people who come back from Iraq. I mean, you name it, we see it. We're looking to see what we can do to maximize its overall function. It's never boring. It's always different. And you can actually try to pull in your clinical reasoning skills, the best evidence that's out there, what the patient values, put it all together and see whether or not you really make a difference.
I see mainly geriatric patients and outpatient therapy. So I treat a lot of the cancer, rehab, and lymphedema population. I think the best thing about being a physical therapist is that you are a motivator and a coach. It's not meant to be deep because the lymphatic system is regular. Yeah.
I am a student physical therapist.
Here, in a neuro setting, certainly you put your hands on, so you teach the patients what to do. But there comes a time where, it is just mental. So you put your hands on the patient, it's now time for them to do as much as they can.
I'm Tim Dockett, physical therapist with Fairfax County Public Schools.
Will had cerebral palsy. There you go. Good. Press it down. Yeah. More than just being a physical therapist, I think we're an advocate. And so we see so many aspects of these kids' lives and that we can help them out. Oh, you're touching the side. Don't try not to touch the blue. Our whole goal here in the middle school is to prepare them for high school. We make most everything into a game. All right, there you go. Oh, nice one. So the more fun we can make something, the more willing they are to do it. Okay, good job. Andy had meningitis when he was a kid and had some brain damage because of that. Great, good job. Good. Stand up there. Don't you sit down. When I had decided to change careers and go back to school, I went and worked in the outpatient clinic and I saw how they were getting people better. Yeah, reach your hand. The people I worked with were great and the difference you made in these people's lives were great. This is Andrew and he's 12 years old. He had cerebral palsy, so he has trouble controlling his movements. And both together, okay, Andrew, stop. Okay. Stop. We want to get them to do as much as they can themselves. If you're doing donuts, that's not supposed to happen until you're 16. It's just fun because you've made a difference.
That's really fun. I'm Denise Constantine. I'm a physical therapist with the Jackson Clinics. You definitely need to have your hands on the patient and feel how the muscles are working and seeing if they're flexible. You have to have all three things coming together: flexibility, strength, coordination. I've actually come from this from the inside out. I was an amputee at a very young age, had a prosthetic all my life. You learn to overcome, and I wanted to teach others how to do that for themselves too.
And what we call the ligaments, the things that keep the leg together. I'm a physical therapist assistant. All right. So now we're working your knees. If you want to be a physical therapist, you want to have a passion for the human body because that's what you do. Human body is your business. Stabilize.
I used to have a problem with walking from the outside of my toes.
So what we wanted to do is teach Nikki to land more with her feet straight. And notice that when her foot is like this, she has got a normal arch. With every physical therapist who works with any athlete, you want to see your person. And I want to see Nikki win. And I want to see her go out there and win medals.
Virginia Howe. I'm a physical therapist. We're in the MACT. It stands for the Military Advanced Training Center.
I just want to get up from the wall. Just run. And I can't. I've learned to do it again, you know. My legs were taken away from me. Now I need to learn how to live all over again.
When you are missing your knees, like Ryan is, and you get mechanical knees or computerized knees, you have to relearn how to walk in a different way than you did before.
I'm the research physical therapist at Walter Reed, and I do a little bit of clinical work through my day, but as a research physical therapist, I'm also doing research through military grants. Andrew's actually just learning on the power knee.
I can see the potential of that speed right now.
All of my day is spent doing amputee research and treating amputees. And then some of our research is early rehab, some of it's late rehab, some of it's to do once you go home. We try to hit all aspects of care. That red line that's coming up when he's walking over this gray area, where the joints that you do have left, your hips and you're on this side, your knee and your hip. You want to kind of minimize those forces or at least make them as normal as the knee would expect. These guys are great to work with. They're unbelievable. It's orthopedics to the extreme, because you're doing sports med, orthopedic rehab, but with a patient population that wants to do that and they don't have legs and they don't have arms, and you have to figure out how they're gonna do it, how they're gonna run and jump and ski.
Like to be able to run my 2 miles in 13.5 minutes.
This will be him in about 9 months to a year.
It's fun, it's creative, and they make it an extreme challenge every day.
Be me. You can be me.
And you can be me.
What kind of patients did you see in that video? So, I will say that this class, especially at night, really sucks if you guys don't talk. Then it's just me talking, and it's not good enough. So, what do you got? What kind of patients? Yep. So, war veterans we saw coming back from a lot of different amputations we got to see. Yeah. Kids. Yep. Anybody else?
Geriatric population.
Yeah, there was one therapist. It was just short, and she said, "Oh, I work mostly with geriatrics," and she actually worked with just. It seemed like it was just people with cancer coming back from cancer. Lots of different cancers affect us. So yeah, any others? Well, one neurological. Yeah. So strokes, I think, and there was one traumatic brain injury. I think one of them had. It was a younger girl. But yeah, what else did you? Some cardiovascular problems. Yeah, a whole bunch, right? A whole big wide variety. What were the PTs and PTAs like? Give me some like personality traits you saw. Happy. Yeah. Yeah. Any others? Like what they're doing. It was clear, even just in the video, like they're into it. They like it. It's yeah. Anything else? Caring, definitely. Yeah. Got to see a lot of problem solving too. I think some of the problem solving was like, oh, the guy with kind of a bigger, lots of muscle guy with the both artificial legs. He had one above the knee, one below the knee. And that person was like looking at the video and saying like, okay, how are these forces? Do we need to change this at all? The one pediatric, it was in a school setting with those blue mats. You guys see what was he doing in that blue mats? Well, how come that kid was walking with his crutches in that blue mat area? Did you guys pick up on that? What stay in a straight line, but also what the therapist had said is you're going to go to high school soon. So we got to get you walking in tight spaces. You got to walk faster. You got to walk in a narrow space because high school hallways are crowded, right? So, yeah, a lot of problem solving. How about the different work environments? What are the kind of work settings that we got to see? Lots of different ones. Schools, yep. Hospitals, any others? Different rehab centers, yeah. What do you have? Yep. Yeah, so we saw at least one like outpatient that girl who was a gymnast or a dancer. I think she was a dancer. Typical outpatient sports type place. That Walter Reed, it's an incredible place. Taking care of all of our nation's wounded veterans. Yeah, pretty wide. And one of the things I love about this profession is just how many different directions you can go with it. You like kids, great, go work with kids over there. You like neurological, great, go work with neurological over there. You like sports, great, got plenty of them. Do you just like everybody? Great, we got places for everybody to be. It's just great. And told you I started an outpatient, did home care, teaching is the best. Like I've almost had 3 different careers in one, all within physical therapy. So yeah, it's great. Just the flexibility we have. So what is physical therapy? The definition, treatment of disease, injury, or deformity through physical methods as opposed to drugs or surgery. That's the big definition, right? So that's the physical thing, right? So what is a physical therapist? Is the professional practitioner of physical therapy. All right, that's kind of a silly definition. Now, this next, the rest of it, God, I'm not going to read it all. I have a better slide later. Actually, I'll just do it. Let's see, where is it? There it is. APTA vision statement. Transforming society by optimizing movement to improve the human experience. So the physical therapist is the person who's responsible for transforming society by optimizing movement to improve the human experience. How much improvement of the human experience did you see in that video? What kind of examples did you see in that video? Moving in any specific patients or things that you saw? I think actually the rock climbers with the wounded veterans coming, like, who are wounded veterans? Typically male and young. What do young males want to do? Crazy stuff. Like go rock climbing when you only have 2.5 limbs. Like figure it out. What are some other things? What are other ways we optimized human movement to enhance the human experience in that video? Some running, yep. And that one guy, did you guys catch what time he wanted to do? He said, I want to run 2 miles. Do you guys catch the time? 13.5 minutes. Like, that's cooking. That's a guy that wants to run. Like, that is something. Why is that important to that guy?
That's his mental makeup.
Type A, gotta go. It's where all of his friends are doing. He doesn't want to float. He wants to go out for a run with the guys. He wants to go be the macho guy that he is, where he's putting it all on the line. I think another one we saw, did you guys see the kid when he was learning how to drive his wheelchair by himself? Can you guys say, I think he said he was 12. Can you guys think of a better way to improve that child's human experience to give them independence in moving room to room? Like that is what we're talking about. That enhances that kid's life. So he doesn't have to ask for help to drive to the kitchen, to go outside, to go down the hallway with some friends. So yeah, that's what our whole career is. So that's what a PT is. Basically, this is a big, long definition just to say exactly that: optimize movement to improve human experience. But PT, the practitioner of physical therapy services. PTA is the clinical-based problem solver. It's the only individual who can assist physical therapists in practice. This is the big thing. So if you've fallen asleep, that video put you to sleep, wake back up, star this in your note, highlight it. Legally, PTAs cannot perform evaluations of any kind. That is the physical therapist's job. We'll get into that a little bit more. Each state does have different guidelines as to exactly what the PTA does. The different laws, state to state, are called the Practice Act. We'll talk about Practice Act over and over again, so maybe highlight Practice Act as well. But yeah, each state has different laws saying what physical therapists can do, what physical therapy assistants, what physical therapy techs we'll talk about next. Just like each state has different driving laws, right? I don't know. I don't know if the driving laws on what age you can get your permit and license is different Massachusetts to Rhode Island right now. Do you know, since you're in both?
Yeah, I could do that one. A little bit different.
Yeah, I mean that's that
Yeah,
little minor things, but that's the same thing as in the physical therapy profession. I'll talk about that in a little bit more, but yeah, each state we have to abide by the practice and the laws of that state, which is called the Practice Act. Physical therapy aides. Any aides in here? Anybody working at a clinic right now? If you're interested in the field, I suggest finding an aide job. Now, I'm going to call PT aides techs or technicians because especially later in the day, my mumble mouth, if I'm speaking quickly, sometimes we can't always hear is, did he say PT aides or PTAs? So I'm going to refer to them over and over again as techs. So PT techs, supportive personnel that can do designated tasks related to operation of PT service. Tasks that don't require clinical decision. That's what techs can do. So techs can clean tables, do the laundry, shovel the sidewalk. Mrs. Johnson just pulled in, walk her from her car in to make sure she doesn't slip on the ice that's out there. They can demonstrate exercises. What they can't do is they can't say, oh, this exercise looks too easy. Here's weight, make it harder. That is the job. So the tech's job should be to relay that information to the PT or the PTA to say, it looks like this is too easy for Mrs. Johnson. What do you think? And then that person gets to make those clinical decisions. All right. Does that make sense how someone can do the task but not do the thinking behind the treatment? Does that make sense? So each state within the Practice Act also has different guidelines what techs can do. In techs in Rhode Island, you can do things like applying the modalities. That's hot pack, cold pack, maybe ultrasound. Use ultrasound a lot anymore. Other states, they're not allowed to do any of that. But in Rhode Island, we can. So this patient climate management model, this is how a patient would interact in the physical therapy world. This is how they would enter it and get service. So it's all going to start with the examination. Examination is testing the patient, figuring out exactly what's wrong with them, really trying to understand all about them and their injury and what their body can and is having trouble doing. Things like how strong are you? How flexible are you? What is your aerobic capacity? What does your skin look like? How much swelling do you have? All of those things are things we would look at, measure, and try to improve upon. Evaluation is the PT can only do the examination stuff. The evaluation piece of this is a little tricky. That's where we take all of the information from the examination and make judgments about it. Normal hip motion is 45 degrees this way. So here's 0 degrees, 90 would be straight across, so 45 is right about there. So that's normal hip motion. For somebody that has back pain, if they only have 40 degrees, all right, they're lacking a little bit of motion. Do I, as a physical therapist, think that's a big deal or is that not a big deal? It's a lot different when we've got a hockey goalie as a patient and they only have 40 degrees. What do we know about hockey goalies and their hips? How much motion do they need? A ton, right? How about Cirque du Soleil dancers? A ton. Gymnasts? A ton, right? So just because one person has 40 degrees and the other person also has 40 degrees, yeah, but this person needs 70, 80 degrees, and this person probably get by with just 40, right? So knowing that examination is measuring how many degrees they have. The evaluation is determining how important is that information. Does that make sense? It's a little abstract. That okay? Diagnosis, we come up with a PT diagnosis. We don't diagnose medical, although we can give some insights to people who can diagnose medically. We diagnose the consequences of their problem. So we don't diagnose heart attacks, recognize signs and symptoms, then call 911. But after somebody has a heart attack and becomes medically stable, we can diagnose them with impaired function because of a cardiovascular issue. That's what the PT diagnosis. I think the prognosis is probably most important for us. So still the PT does all this work so far. PT also comes up with the prognosis. Prognosis, there's 3 major points to the prognosis. Number 1, how much better is this person going to get? Number 2 is how much time is it going to take? And then number 3, we write the plan of care. The plan of care is all the specifics about the treatment that we're going to apply to this patient. We're going to give them. The analogy I like to use is your plan of care is like a recipe when you're cooking. Anybody here just an okay cook? Yeah. So you need a recipe, right? If you're going to cook something new, you say, give me the recipe and I'll follow it, right? Now, when you're trying to make that thing, you're allowed to make little changes within that recipe, right? Recipe calls for a lot of butter and you don't want to use a lot. I'm going to use less. What's another substitute? What's a common substitute? In baking, there's a lot of substitutions, right? What's a substitution in baking? I'm not a baker. Like applesauce instead of sugar. Is that something? Or am I making that up? Honey, you using honey instead of something else? Yeah, sure. So, the plan of care in the physical therapy world, it's the recipe, it's the guidelines. You have to stay within the plan of care. But you, as the clinical decision maker, get to make determinations about what you do within it. So I think that guy that wanted to run the 2 miles in 13 minutes, he had both legs amputated, right? Both above the knee. So my prognosis is, I mean, we're not testing that guy. He's not in front of us, but do you think that guy's going to get back to running? I don't think there's anything stopping that guy from getting back to running. I don't know if he's going to make his 13 minutes and 2 miles. I don't know. I would never promise that. But if I were to bet money, I bet you he's going to find a way. But I will also tell you, it's going to take us 6 to 10 months before we get to running. That's what my prognosis is. Start running, jogging at 6 to 10 months. You get as good as you want there. But my plan of care is also, this guy can't even stand up by himself yet. This guy can't walk without his walker yet because he's still learning how to use these new devices, right? So as I make that plan of care, step one is we've got to teach him how to put these new prosthetics on and off. We got to teach him how to inspect the skin to make sure the skin is staying intact and not having damage to it. We've got to get him walking on level ground with his walker, and eventually we're going to go down to cane. And then eventually we're going to go to nothing. And once that goes really well, then we get to start increasing the speed, right? We've got to introduce uneven ground at some point. So my plan of care is going to be, prosthetic training, education on skin, transfer training. Transfer is the act of getting up and down, gait training, decreasing assisted device. I give you that plan of care as the PTA. You get to work with your patient and say, you're ready to get rid of this walker, bud. That's how you get to advance the patient and stay within the plan of care. Now, if I don't write running in that plan of care, you can't say, let's go for a jog. No, that's not in the plan of care. You can't do that. There are times I make a mistake writing my plan of care. I can think of plenty of times I'll have patients that loopy from pain meds, just not safe to try stairs with them today. And then I'll give him my PTA, and my PTA will say, Josh, did you not see this guy? He's got terrible balance. I go, no, he was on pain meds and I didn't get a chance to really. Okay, let me adjust the plan of care. Thanks for letting me know I made that mistake. Let me adjust the plan of care so you can work on something. I'll test it and work on that plan of care. Okay. So does that make sense on the what the plan of care is? If I'm going to give you a recipe and say, bake me blueberry muffins, all right, well, you can figure out how many blueberries, you can figure out how big they should be, you can small, you substitute this ingredient for that one. You can't make me donuts though, because that's not within the plan of care, okay, if you're going to stick with that analogy. So the PTs come up with a prognosis and the plan of care. Interventions are those daily visits. Basically everything we just saw in those videos were revisits. PTs or PTAs can do either of that, right? So that's the first time the PTA gets to participate in this process. If everybody does their job, we have successful outcomes. Outcomes are what the goal of this whole treatment is supposed to be. There are 3 main goals for any of our patients, and what all of the details we figure out But the three main goals: improve current level of function, abbreviated CLOF. That guy that wants to get back to running. Great, that's a great goal. But guess what? You can't even stand up without help right now. So we better start working on that because you're going to need to stand up pretty soon. So improve current level of function. Man, if that guy was with us and I could help him get out of the chair by himself instead of having to have someone else help him or almost fall down, we've just improved that person's life significantly, improved his human experience, right? So that's number one, improve current level of function. Number two, not everybody gets to do this, but a lot of our patients do, is return to prior level of function. PLOF is the abbreviation for that. So if I walk out of here, slip on the ice, hurt my shoulder as I break my fall, well, if you're going to help me, if physical therapy is going to help me, you want to get me back to where I was before I fell, right? That's the prior level of function. Not everybody can. That guy with the bilateral amputation, he can't return to his prior level of function. He's always going to have an altered level of function because he doesn't have his legs yet. All right. Doesn't mean he can't run, but he's going to run way differently. There are other conditions that are progressive. So like Parkinson's is a progressive condition. That person's, if they get diagnosed today, in 5 years, they're going to be worse. That's a progressive condition. So we're not always looking to return to prior level of function. But anyway, we'll look at that. The last major outcome is prevention of future consequences. So if my patient had a heart attack, all right, well, step one, we've got to improve current level of function. That means we got to get out of bed. How are we going to get out of bed, get dressed, get bathed, and walk and make yourself a sandwich? We've got to accomplish those tasks. Return to prior level of function, man, depending on the severity of the heart attack, I'm not sure, but you should be able to return to work. You should be able to return to leisure, like whatever you like to do, as long as it's not crazy. Like we should have we should be able to get back. What do you think the major thing to prevent future complications for somebody who had a heart attack is? Change the diet, prevent the next heart attack. Like you got a heart attack for some reason, man. Let's not get another one. We got to make sure you're talking about diet, you're having regular cardiovascular exercise, you're weighing yourself all the time. Like let's figure out how we're going to prevent this from happening again. Yeah, and that could be for any single thing. Anybody here sprain an ankle? Yeah. Guess what our goal is? Don't sprain the ankle again. like step one. All right. Well, what happens with a sprained ankle? How did you guys feel after your sprained ankle? Ow. Tell me what was wrong. Like you sprained your ankle today, and then tomorrow, what do you do? Try not to what? Walking sucks. Stairs are awful. Uneven ground, can't do it. Can't go to the gym, can't do a sport, whatever the sport is, right? All right. Well, we want to improve current level function. That means let's make walking suck less. How we do that depends on the ankle, but yeah, let's make walk suck less. Probably right in different terms than that in the medical record. Return to prior level function is get back to playing basketball, get back to playing soccer, get back to going to the gym, right? That's that. Prevent future consequences. How come you had this ankle sprain? How are we going to prevent it from happening the next time? Does that make sense? So that's it, all written out there. I just want to highlight, what's a celebrity we all know? Anybody got? I don't know any celebrities. What's a celebrity we all know? I taught this class at 2:00, 2:30 down in Warwick, and they chose an actor too. All right, so Ben Affleck, Boston guy, right? He's a Massachusetts guy, right? All right, what do we know about Ben Affleck? Did he just get divorced? Did they split up again? Maybe the third time's the charm, Ben. You got it. All right, what injury do you want to give him? Torn rotator. The last class shows that too. This is weird. All right, torn rotator cuff. All right, so the rotator cuff is a group of muscles in the shoulder. Does he have kids? Do we know? Approximate ages? What do you think? We'll give him teenage kids. Okay. All right, so injured rotator cuff severity, we don't know. Let's make it minor. Will that affect his job? Acting. Okay, so and especially depending on the role, especially if there's a physical scene. The last class shows Tom Cruise, and Tom Cruise famously does all of his own stunts. So, all right, well, that's a big deal for Tom Cruise. I don't think he was Batman, right? All right, so if he's doing the next Batman or the next yeah, all right, that's a big deal. Like if he can't perform those tasks as an actor, man, if they've got to shut down movie production, how many jobs are reliant on that? Not never mind other actors, camera guys, food services people. Like that's a big deal, right? Different than if I have a rotator cuff injury, right? Can I still work if I had a rotator cuff injury as a teacher here at least? Might have some trouble patient care. Yep. How about driving? Is that going to be challenging for me with injury? Potentially, especially depending on severity. How about Ben Affleck? So it would still be the same problem. Can he find a way around it a lot easier than I can? Yup. Ben Affleck's got plenty of money, and you know what? The movie producers, they'll grab him a car anyway. So I carry my kids to bed at night. I have an 8-year-old and a 3-year-old. I carry them to bed every single night. My 8-year-old less and less often, but my 3-year-old, she's in my arms. If I can't carry my daughter to bed, my son won't let me anymore. Man, that is going to break. That really sucks. Ben Affleck, if he's got older kids, grown out of it, also pay someone else. you carry it. So we both have the same injury. We both have the same problems. How it affects us is going to be way different. So with Ben Affleck, we don't care if he drives anytime soon. He's got to get back to being an actor, and we're going to figure out exactly what does that mean. For me, you better get me driving quick because my job depends on me driving. So that's how we can both have the same examination. We both have injuries. We both have range of motion and strength and pain. But the order of importance is way different, and that's going to affect our prognosis and plan of care a lot. So that's how that process would work. Does that make sense? So what interventions can be delegated to PTAs? Anything that's included in the plan of care. Again, if it's not in the plan of care, you can't do it. But stretching exercises, strengthening exercises, balance, pain management techniques, modalities. Modalities are anything we apply to the patient, as easy as a hot pack or a cold pack. Ultrasound, different e-stims, cupping, kinesio tape, all of those count as different modalities. Different manual treatments, massage, joint mobilizations, whole bunch of different types of manual treatments we could do. But again, PTAs can never perform an evaluation. That's going to come up frequently on your tests, and make sure we understand. Some interventions that PTAs cannot perform, these do vary state to state depending on those state laws. What's the group of laws that each state has that governs what the physical therapy profession can do? What's that called? Mentioned it a couple of times, I think. Maybe just once. Practice Act. Great job. So spinal manipulations is something I, as a physical therapist, can do, but PTAs cannot. Wound debridement with sharps. Anybody know what that is? Remember what that is? Your wound debridements with sharps, you remember?
While you work with them?
Yeah, so if they already have a wound, the problem with wounds is when dead tissue grows in it, that dead tissue um, blocks good tissue from healing and taking its place. So that's what wound debridement is, the act of getting rid of that necrotic dead tissue that's in the way. Sharps refer to collective term for instruments like scalpels and tweezers and other things that can actually remove tissue. So I, as a physical therapist, could look at a wound and grab a scalpel and say, this tissue is not good, let me remove it. This tissue is safe, I can keep that there. This is no good, remove it with scalpels. I could do that. I won't. That is not something I want to do. I know one physical therapist that's all he does is work with wounds all day long. And he makes a ton of money and he has way more work than he could ever accomplish in a day or a week. He is one of the most sought after physical therapists around because he's really good. You have it. I don't need it. You have it. I'll go teach. I think it's way better, but you enjoy. Now, PTAs can perform different types of wound debridement. Some of it is, one of it is called a pulsatile lavage, is another name for it, but basically it's taking a water gun and squirting it in the wound. That velocity of water just helps remove some of that tissue. The other one, we don't do it as often. It's called wet to dry dressing. So you take gauze and you wet it with saline and you put it on the wound and then you let it dry. And what do you think the next step is? Yeah, you rip it off. That takes off the problem. We don't do that a lot because it takes off a ton of good tissue too, not just the bad tissue. But those are some things. So PTAs can participate in wound care. Just you have to have different techniques for it. So, but anyway, we'll look at some of that stuff. So some of the settings that we can work in, this is just a partial list, but the major ones are here. Hospitals, there's also specialty hospitals. So general hospitals, Rhode Island Hospital, Kent, South County, Newport, those are Miriam general hospitals. They have some specialty programs within it. Those are general. Anybody's got a problem, you can show up there. There are a few specialty hospitals in the state. Anybody think of a specialty hospital? There's 4 types in the state, I think. Hasbro, there we go, right somewhere there. I forget which direction, but yeah, there. That's the way. Bradley is another one, right? So Hasbro, pediatrics, Bradley, more mental health related. Good. Butler, yeah, Butler's the one I was thinking of, not Bradley, but yeah. Any others? Women and infants is another one, right? If I get a broken bone, I show up at women and infants, they're gonna say, hop on down the road, man. You're not here. Go away. Same thing if I showed up at Hasbro and I said, hey, I got a broken leg. They're gonna say, yeah, you go that way. There's also in Rhode Island, there's 2 different rehab hospitals. We'll talk about those some other time. But they're pretty fun. They're fun for us to work at. Skilled nursing facilities. Skilled nursing facilities are often abbreviated SNFs. We call them SNFs. So if you ever see that, just be aware of that. There are some specialty skilled nursing facilities in the country. I don't know of any in Rhode Island. There is one in the Boston area that's a pediatric skilled nursing facility. But there are some across the country, some specialize in brain injuries or spinal cord injuries. There's some throughout the country. We don't have any in Rhode Island. Home care, that's where I work in now. Outpatient practice, that's where I started my career. Academia, anybody know what that is? That's here. Yeah, that's what I'm doing now, working in academia. Schools, we saw some of that in that video. Every single public school is required to have a physical therapist for the kids who need it in their school. And other, not only PT, but occupational therapy, speech therapy, and others as well. But then on and on and on. I met one PT. He worked with a traveling theater group. It was, I forget the production. It was high level. like a Cirque du Soleil type thing. Like, yeah, there's going to be people taking care of those performing athletes. Sports teams, others are equestrian and other pet PTs. I know I have two former students that now only work on dogs. Pretty cool. Yeah, one of them said, "I'd rather get bit by dogs than humans, so I'm gonna go work over here." I said, "Who bit you?" Can't. And others just depend. There's different parts of the country where equestrian happens, where you can work on horses itself. Um, some big money. Yeah, I mean, if you've got horse that, yeah, there can be some big money there. It's a real unique area. Anyway, let's talk about the APTA. I think I mentioned the APTA already. American Physical Therapy Association, private, nonprofit, member-driven organization, oversees the entire profession of physical therapy. It is the governing body of all physical therapy, education, testing, licensing, practice. It is the big governing body of all of us. You don't have to become a member, but if anything were to go wrong, the APTA is going to be the one that sets forth the guidelines of how you should have acted. We'll talk about that in future weeks. So any student PT, student PTA, or licensed PT or PTAs can be members, and that's it. You can't be a member if you're not one of those things. It's the guiding professional organization that oversees all of practice, education. We'll talk about CAPT, and then the licensing exams, FSBPT. We'll talk about that in just a second. So the national level, the APTA is broken into sections. They're being renamed academies. I think they're about 50% of them are still called sections, 50% of them are called academies. And they're just the practice topic you like. That's how they're broken up. It's governed by the board of directors and then the House of Delegates. Each state is represented by a chapter. No. I am on the board of directors in the Rhode Island chapter of the APTA. Forgot to tell them their meeting started at 5:30. I forgot to tell them I wasn't going to be there, so not a very good effort. So other groups can join together in a couple of different ways we'll look at later. So how is the APTA structured? Nationally broken into academies or sections, governed by the board of directors and House of Delegates. The House of Delegates are the policy-making body of the APTA. Each chapter gets to send a delegate. So it's a little bit like Congress, like each state gets its own person just to vote on it. Board of directors are 16 elected members who guide the APTA in a variety of ways. The academies, there are 18 areas of interest: acute care, which is more hospital-based; aquatics, cardiovascular, pulmonary; electrophysiology and wound management; education, federal; geriatrics, hand and upper extremity; health policy administration; home health; neurology; oncology; orthopedics, pediatrics; private practice; research, sports, and pelvic health. Pelvic health is a pretty interesting one. I think oncology is really interesting as well. So yeah, a big area. So all of those things and work settings that we saw in that video has its own academy that you could look at and learn way more than you could ever even take in. It's really incredible. So there's about 100,000 APTA members. There are also called special interest groups within each section. So there is a performing arts special interest group. That's where all physical therapists, physical therapy assistants that only work with theater productions and musicians and other things like that all get together and share knowledge and get jobs. Animal rehab is also in orthopedics. So there's a whole bunch of special interest groups. There's a breast cancer specific special interest group in the oncology one, schools, PT, and the pediatrics one. So different, just a way to narrow your focus. Students can belong to the student assembly, and this is important. PTAs can belong to the PTA caucus. It was recently renamed something else. I've got to look up what it was renamed to. But the PTA caucus is really important, especially for you guys, because that is responsible for discussing only the issues that PTAs face. So you get to have a good collective voice to solve whatever those problems are. So like I said, each state is broken into chapters. There are 51, one for District of Columbia, and then one for each other state. Some larger states get broken into districts as well: California, Florida, Texas. I know have different districts to it, but anyway. Other organizations related to the APTA, CAPT, Commission on Accreditation of PT Education, they are who oversee education. So every single, I think it's every 6 months, we have to submit letters to CAPT saying we're doing a good job, we're doing a good job. And then every 5 to 10 years, they come in and they audit, they go through all of our files and make sure that we're doing a good job. And they say, okay, you can still offer this degree. They do the same thing for PT programs as well. Federation of State Boards of Physical Therapy, they help regulate the profession, but the other big thing they do is they create the licensure exam. So I said earlier, after you graduate, you have, in order to become a PTA, you have to graduate from a CAPT-approved school like us, and then you have to pass a licensure exam. The licensure exam is 180 questions. You have 4 hours to do it. It's all multiple choice. That's why all my exams are multiple choice, because test taking is a skill, and we're going to get better at that skill. So, and then there's also political action committee that's important as well. So some benefits of membership, I will say, anytime I've been involved with the APTA, it's advanced my career. I started teaching. My wife was, she was in the APTA. She was running the education. She was running a lecture at New England Tech. And my wife does this thing. I don't know if anybody here does it or anybody here's. This is what she does. You ready to go? Yeah, let's get going. And then 45 minutes later, I turn around and she's still talking to somebody. Does anybody else? You know somebody that does that, right? So as she's pulling that move, I talked to an old professor of mine who's running the New England Tech program. I said, "Hey, how are you?" He said, "I don't have anybody to teach on Monday. It's a Thursday night." I said, "What time's class?" I got some flexibility in my schedule. She goes, "I'll email you tomorrow." She emails me tomorrow. You got the job. But what time is class? I don't know if I can do it or not. That's how I started teaching. And every single big jump in my career, I can point to something that the APTA, I was with the right people, I learned the right thing, and so that's the biggest thing that I can say with my career and how important the APTA is. But there's a lot of others, access to resources, a lot of different research, a lot of different education opportunities, career advancement, networking. And then the other thing, just like any organization, like a AAA, there's a whole bunch of discounts on a lot of other products, malpractice insurance, car rentals, hotel stays. There's a whole bunch of things like that. So I think it's definitely worth it. So we already went through the vision statement, which I love. Optimize movement to improve the human experience. I'm going to go through the history. Do we have any questions to this point? All right, we're going to quickly go through the history of the profession. Evidence of physical medicine as early as massage, Chinese literature, over 5,000 years ago. Are we writing BCE now? I was reading something in my son had something he was reading, and I think it said BCE. Did anybody? I read that. I was like, what are they talking about here? Oh, anyway. Hippocrates in 460 BC, hydrotherapy. This thing blows my mind. Electrotherapy techniques in the 1600s. I can't really wrap my head around that. I just envision like somebody with a key tied to a kite and like the other end. Do you feel better yet? I just can't figure that out. But pretty incredible. So the big thing I want you to understand is the two major events that started the growth of the physical therapy world and always increased the demand of all of medicine, but especially physical therapy, is disease and war. Those are the two events that will always increased the need for all of healthcare, but physical therapy as well. So the first two instances, the polio epidemics, and then World War I. World War I is when medicine was advanced enough where we could fight infections and somebody could get injured in war and live. Prior to that, if somebody got injured in war, infection was going to take. So we started having these war veterans that were surviving these injuries, and then we had to figure out, well, how are we going to get this person functioning in their life again? So in 1917, the U.S. Surgeon General sent a group of physicians to England and France to learn PT techniques and take care of their wounded. That was the first formal education of what was then called reconstruction aids. Reconstruction aids were the first PTs and then occupational therapists. We'll talk about occupational therapy later in the semester as well. So here she is, Mary McMillan, known as the first physical therapist, my celebrity crush. I'm not afraid to admit it. She was also the first person. She started and was the first president of the American Women's Physical Therapeutic Association, which was later renamed to the APTA. And then in World War II, a second wave of polio, and the Second World War increased demand again. So our profession just grew exponentially because of that. And I will also say, even in the last 20 years, recently with COVID and then the Middle East wars have shown that the same thing rings true. Wars and disease will increase our demand considerably. And actually, especially in the last 20 years, the advancement of the prosthetics has been incredible to watch over the last 20 years. It really is something. And we saw a lot of that in that video. So early years, the 60s to the 90s, big development in education. Some of the other factors that influence growth, aging population. Who requires more healthcare, younger people or older people? Older people require more. So when we increase our life expectancy, there's going to be an increase in demand of healthcare services, including physical therapy. I will also say another thing that's a little bit unique to our culture in America. There's a big independence as we're aging. You'll need to maintain independence for as long as possible, which means you need to maintain your physical mobility and enhance that human experience. Where other cultures, it's less important. There are some other cultures that say, no, mom and dad, as they age, they move in with us and we have this 3-generational household and we all take care of mom and dad or grandma and grandpa. Where in America, we're very much, you go live by yourself, stay there. And then the individuals say, I don't want to move in with you. I want to live here as long as possible. So that's another little bit unique thing in our culture. Federal healthcare coverage increased demand as well. We'll talk about that later as well. More focus on health promotion and disease prevention. And the big thing here, we're going to talk about this over and over again. So highlight this too, increased use of direct access. Direct access is the right to conduct physical therapy without a physician's referral first. So if somebody sprains their ankle walking to their car tonight, if you let me know, I would find someone to see you tomorrow. I could, without a doubt, find someone to see you tomorrow. Might have to travel a little bit, but at least you'll be seen. That's because of direct access. If we didn't have direct access, that means you would have to see your physician first. When's the next time? Today's Wednesday. So if you sprained your ankle tonight, that's what, they're closed already. Could anybody get in to see their doc this week if they called them and said I sprained their ankle? Probably not, right? So it's next week at a minimum, right? All right. Well, now that's at least 4 or 5 days. What are you going to do for 4 or 5 days with a sprained ankle when you could have just gotten treatment right away for, right? So that's what direct access is, skipping that needless step of seeing the physician. That's a great question. So one of the things that I am responsible for as a physical therapist is to make sure it's not something more serious that I can't handle. So there's a few tests I can do that will say this is likely a fracture or this is likely not a fracture. So it's up to me to do those tests for it. So yeah. Yeah. Yep. Yeah. So and that just changed. The X-rays just changed in the last years with in Rhode Island. Other states it's been longer. But yeah, we have the ability to do that. So yeah, to make sure it's not broken. Yeah. So. So modern skyrocketing healthcare costs and increased focus on evidence-based practice. Evidence is what you're doing actually working, or is this just all a sham? Like, let's make sure what we're doing is actually working and have some research behind it. In the early 2000s, the APTA put forth Vision 2020 statement, which was the goals were to increase autonomous practice, that's increase more direct access, move the education level to the doctorate degree. The reason why we moved it to the doctorate degree is so that we would have the ability to know what we shouldn't be treating and that we could strengthen our need and use of direct access. Evidence-based practice, professionalism, branding. Branding, I'm a little skeptical on. I guess it's okay, but anyway. So here are some important abbreviations to know. I think we covered all of them. But let's go back all the way. So like I said, these learning objectives are the things that your flashcards, however you like to study, are supposed to be geared around. So what are the key definitions of physical therapy and physical therapists and PTA? So physical therapy, what is it? Treatment of transform society, optimize movement, yeah, and to improve the human experience. Yeah, and I think there was another definition of treatment with physical as opposed to drugs or surgery. Physical means as opposed to drugs or surgery. That's the big definition of physical therapy. How about physical therapist? Kind of a silly one. Someone who practice, yeah, yeah. And I think the big thing for us is to remember that physical therapists are required to do the evaluations. PTA, clinical based problem solver, right? And legally cannot perform evaluations, but can perform interventions within the plan of care, and we call it the scope of practice when you're practicing within the State Practice Act. And then technicians, supportive personnel that can't do clinical decision making. Yeah. What's a list of interventions that could be delegated to the PTA? Stretching, strengthening, balance. What do you say? Modalities. Yep. Massage. Yeah. Hands-on techniques, including massage. Yeah. All of that counts. Good. And that's only a partial list. Remember there's certain things that PTAs cannot do, like manipulations, wound to breed, wound sharps. So, briefly, history of the APTA and events that increase demand for the profession. Broadly speaking, two events are always what? War and disease, and the first instances were what? Polio and World War I. Those are two big ones. Recent change of the profession, more of the Vision 2020 stuff. So anything along those lines? Doctorate of physical therapy. I think direct access is the major one that we keep talking about over and over again, with a few others. PTA assembly. In the APTA, there was one group that only was focused on problems, issues of the PTA. You guys remember what that group was called? PTA caucus. Great job. What are a few benefits of the APTA membership? Yeah, so some discounts on some stuff. Yeah, great. Yep. Anything else? Yep. Networking, big one. Some health insurance, yeah, some health and life insurance, definitely malpractice insurance. I think the big thing is access to education and other resources. The Because I'm an APTA member, if I had a patient, I'm seeing them tomorrow, and I look and they've got a condition I have no idea anything about, never heard about it, it's unusual. I can log on to my APTA, enter in my membership, and I will find every single research article about that topic. And there's probably a few hours long continuing ed video that I could purchase and say, now I know enough to work with this person. I could do that tonight. So that's, I think, the best thing that the APTA does. It gives you that little safety net of here's all the education of everything we know about physical therapy is within this APTA somewhere. So I could also I could call the APTA and say, I'm in a real jam with a patient. I need to talk to somebody with experience. They'd be able to find me a network of somebody that's really knowledgeable in that. So those are the big ones. Organizational structure of the APTA. Nationally, it's broken into what? So each state is represented with its chapter. Nationally, it's broken into topics of interest that are called what? Either sections or academies. Each state sends someone to vote on all of the issues of the day. So what was that called? The delegates. So they are the delegate and they work in the House of Delegates. And then there's 16 people that are even higher than them that guide the APTA. Is what are they called? Board of Directors. Yeah. What are some employment settings? There's 5 major ones and then a couple other fun ones. Hospitals, skilled nursing facilities. What did you say? Outpatient. Academy. Oh yeah, academia. Yeah, yep. Home care. Yeah. One major one up there. Schools. Yep, schools. Yeah. Maybe that was the schools. Yeah. So, yeah, hospital, skilled nursing facility, home, outpatient, schools are the big one. Academia, and then, gosh, it really is infinite beyond there. But those are the major ones. Most PTs and PTAs work either in hospital, skilled nursing facility, outpatient. Those are the big 3. Outpatient's number 1, skilled nursing facility number 2, hospital number 3. Less home care is 4. Schools, there's not a lot. Academia, even less. So, but those are the big ones. All right. Do we have any questions? So the syllabus says we have homework to do. I changed that, but I didn't edit the syllabus. I apologize. No homework for this week. I want to leave you with this one thing. That's good. So I hate once a week classes. The reason I hate once a week classes is because it lulls us into sleep of thinking that I'll just learn this stuff, put away my stuff, and then we'll talk about it next time. If the next time you look at this material is next week, research will say that you'll have forgotten between 80 and 90% of what you just learned today. When we have a class twice a week, I get to say, hey, do you guys remember what we learned 2 days ago? And I get to have that constant contact. When it's only once a week, you don't have it. But it doesn't take much to slow down that curve. Some people just remember everything. I had one classmate, a photogenic memory. He just had to flip through the textbook once, and then he just learned everything. It was amazing to watch. So much. It was amazing. Other people that forgetting curve is even faster. Other people are forgetting stuff before they even finish driving home, especially get a long drive. What I'm begging you to do find a way. I call it touching the class. Studying isn't always locking yourself in the library for 3 hours and saying, read every single word in the textbook. That's not what studying is. Studying can be as simple as, man, if tomorrow you took those learning objectives and you made flashcards for half of them, great, that's all you got to do. Take 30, 40 minutes to do that. Do another 30, 40 minutes the next day. And then the rest of the week, you just look at those flashcards. Man, now you're going to be somewhere over here, 100 to 90 to 100% of that information we covered today, you'll have in your memory. If the only time you look at this class is when you're in this class, and then before an exam you try to study, you are not going to do well. So I beg you, look at the learning objectives and study before you get to class. We'll talk more next week on how to do a better job learning. What I will also preview this on is if you could just peek at next week's material, you'll set yourself up for success as well. Anybody ever try to watch a movie without watching the trailer first? Weird, right? Is this a comedy? Is this guy hate that guy? Is he a killer? No, he's just a loof guy that's, like it's really weird. But that's exactly what we do when we show up to class, not knowing what we're about to talk about. So all it takes is pull up the PowerPoint, glance at it. 5 minutes, and that's good enough sometimes. So I'll talk more about that in the future weeks. But for now, I just beg of you, study this material that we just covered before you come back in. Okay? All right. Do we have any other questions? I appreciate your time. I appreciate you actually guys participating in class. To me, it is really boring when I'm standing up here and being the only one talking. So I appreciate your involvement in this class. So thank you so much. Any problems, email me. And then we'll see you next week. There are 4 people I think I need to grab attendance for. So come on up before we go. The rest of you have a wonderful night. Have a good luck studying.